the prostate so basically, of course, the real one is much smaller than that, but just to represent the prostate here, you have in both sides of the prostate nerve bundles. If you damage those nerve bundles, what happens very often in surgery and radiation too, the patient has erectile dysfunction because those nerves are responsible for erections. And if you damage the sphincter, which is in the urethra, the patient has urinary incontinence, and the rectum is just behind the prostate, very, very close. So it's a very challenging environment, very, very difficult to navigate. This is why we have so much side effects, because when they remove the whole prostate or when they radiate the prostate, they finish by either damaging the nerves or reaching other organs around. The radiation is obviously not perfect either, because basically what happens is we have to cross other organs for reaching the prostate. So if you finish damaging other organs too. Okay, so the term focal therapy actually has been more or less invented by Professor Mark Emberton from London, which is a friend of us. And it means what? The main idea is not removing the whole prostate or not treating the whole prostate, but treating where the cancer has been localized. And pretty much is the last organ in the human body. You're still treating by removing the whole organ or radiating the whole organ. Or all the other cancers, they have some kind of local treatment. So the idea is, of course, when it's possible, to localize the treatment where the cancer is. So there is some words here to say. I think they're important too. Most of the people doing focal therapy with HIFU or sometimes even with cryoablation, they try to really focus on a small area where the tumor is. So our experience is a little bit different. We have now a series of hundreds of patients we have treated, and we know if we treat just a little region here where the cancer is, there is a big chance to have cancer popping up elsewhere here. So most of the times what we do is we find cancer in one side, we do what we call a hemiablation. So we destroy half of the prostate just to avoid to find cancer down the road in the other side. So what is important here to understand, I don't know if you did the picture here. Yeah, what is important to understand is with existing techniques like cryoablation, for example, if you have a cancer, because most of the cancer in the prostate, they are in the posterior part of the prostate, close to the rectum here, 2/3. 1/3 is anterior. If you place a cryoablation probe here, you generate what we call an ice ball, and the ice ball expands and destroys tissue. So if you stop the organ generator, the ice ball continues to expand a little bit, even when you turn the system off. So that makes it very difficult to treat cancer posteriorly with cryoablation because of this expanding ice ball. The HIFU is another popular kind of modality of treatment. The HIFU destroys only a small portion of the prostate at a given time. So if you have a bigger area to treat, what happens is you let cancer in between those destruction zones. And we have seen patients with HIFU failure because of that, because we let cancer in between those ablation zones. And basically, the difference between our technology, HIFU or cryoablation, is we use what we call the Faraday cage effect. I don't know if you're familiar with the Faraday cage effect. Basically, the Faraday cage effect is the same principle that protects you in your car if your car gets hit by a lightning, because it's a metallic cage. And you see the guy inside this metallic cage, the energy cannot penetrate inside because the metallic cage creates what we call a shield, a Faraday shield. And we use exactly the same kind of effect for protecting the nerves and protecting the urethra within the prostate. So, so we can, let me show you how the device looks like. So basically, it's a coil device with a needle in the middle. It's a bipolar radio frequency device. And this coil generates the Faraday cage effect. So we can, going back a little bit here, if you have a tumor zone here, we can place a coil exactly where the tumor is, And less than 1 millimeter away, there is no tissue destruction at all, because we have this fabricated effects protection. There's a shield, an electric shield. So, so we have today the only technology allowing us to get very, very close to the nerves, very, very close to the rectum or the urethra, and not destroying those important organs. And that's the advantage, the technical advantage we have here. So, what is important also to say is, our procedure is totally percutaneous, that means there is no incision. Those electrodes are inserted but through the skin. We see what we are doing in real-time ultrasound. So we see the coils within the prostate. So if the coil is not in the right position, we don't launch the radio frequency. So it's a double check. So that's the only technology that allows us to predict exactly what we're going to destroy before destroying anything. Because we see the coil on the ultrasound. If the coil is not on the right spot, we remove the coil, replace the coil again. Now it's on the right spot, then we launch the radio frequency. And when we launch the radio frequency, we have an ablation just inside this coil. The tissue is destroyed by thermocoagulation. It's a radio frequency-based device. So also important to say that I mentioned that we have no incisions, there is no hospital stays. We are doing that in office, and just to give you an example of our results now. So we don't have patients having side effects like erectile dysfunction. And in the series we did in one of the clinics we worked with in Orlando, 100 plus patients, we had one failure. So it's a good result. And patients basically they recover very quickly back home in a couple of days. And some patients we have to let the Foley catheter for 1 week. So it's a little discomfort for one week. Then it's normal life. So that's pretty much it. I suppose you have questions.
How do you get the coil inserted, or how does that
it's percutaneous to the skin. No. Actually, the coil is like a curved needle.
Yeah. If everybody, so there's an area called the perineum, right? So the perineum is the small space between your rectum and your testicles. The prostate sits right behind there. So the needle is very sharp, and although it is curved, it is very sharp. And it just gets introduced, and the urologist, board certified urologist, twists it and turns. Like, how many people have opened up a bottle of wine? I'm sure everybody's hand is go up. Very similar, except it's done.
Is this the same size as a biopsy needle would be? I mean,
Actually, the trauma is inferior than the biopsy, because we insert a few coils. The biopsy needle, they place a lot of needles, much more needles than what they do. So what the patients tell us is that the discomfort they have during the biopsy is far worse than our procedure.
And how are you guiding the
real-time ultrasound?
real-time
transrectal ultrasound, yeah. So here, you see the rectum is just here, right? So we insert an ultrasound probe here. So the ultrasound probe is very, very close to the prostate. So we see the prostate very well on real time. And again, we see the coil as well. So we know where we are. We know because we knew previously where the cancer was found, because we have the biopsy results and eventually an MRI. And we place the coils where the cancer has been found, and then we launch the radio frequency. They typically takes between 35 and 45 minutes, typically.
Do you aim particularly at the lesions, or do you do the entire prostate?
That's a good question. It depends on the case, Usually people don't do focal and the whole prostate. We do. We have a case, someone here from Sarasota, by the way, became a good friend of us, and a young guy, 57 years old, very good shape, and he was in panic about getting a prostatectomy, because he had a very good friend of him who had prostatectomy and had all the side effects, erectile dysfunction, the whole thing. And but the problem is everybody turned him down, because the cancer was all over the prostate. I think it was eight or nine positive cores out of 8, right?
8 cores of Gleason 7.
8 cores out of 12. So that's what was all over. Right? We did the case. We made sure we kept the coil inside not damaging the nerves. And his PSA was 5 or 6. No?
5.7 at the time of procedure.
Yeah, 1 year later, 0.4.
Does this work better on an enlarged prostate or a small prostate? Did you find a difference
In his case, it was a small. Yeah, in his case, it was a small prostate. Well, which is very challenging because you can damage much easily what is around. But we did the case, and we have done other similar cases too. So we have a very few limitations, So we don't have a limitation in size, unless that happened maybe 1 or 2 times, unless it's a giant prostate, and the prostate is behind the bone because I have a pelvic bone here, so we cannot have access to the whole prostate. That happened twice for a series of 200 plus patients.
This doesn't require
What do you do with multiple lesions? Say if you have 2 or 3.
We use several coils, and we have different sizes of coils.
So you do each one individually?
No. No. If you have, for example, here, we found there was a lesion here, a lesion here, a lesion here. Okay, so then we are going to do a hemiablation. Okay, we do a hemiablation. So we place a big coil here, we ablate, and then we place another big coil here, another big coil here, and we destroy the whole region.
So I understand your question. One second. I understand your question. If there's multiple cancerous lesions,
right,
we can use the same coil, insert it once, ablate a region, back the coil out, reinsert it like a Venn diagram that would go overlapping the other region of the coil's hair, but hitting the cancer that's there. So we can take it out, put it back in, and re-ablate the other cancerous areas. If that makes sense.
Yeah, but what is important is we overlap
procedure.
We overlap the destruction zones. That means if we have a lesion here, we place another coil overlapping this coil here, then another coil overlapping, because we don't want to let cancer between the ablation zones. So basically, we end up with a unique ablation volume. That's the difference between our technology and IQ, for example.
In my conversations with the urologist, mentioned 2 lesions and said, well, you're not a candidate for because of having multiple lesions.
Yeah, the problem is, let me try to explain that on a simple way. The problem is there is, I would say, in medicine, there is a general rule, is what you learn in the school has been invented and developed 20 years earlier, right? And then you spend 10 years in the medical school, and then 10 or 15 years later, we are doing the same thing they are doing 40 years ago. Okay, so and it takes a long time for changing the community. I would say the community habits about new treatments. So most of the urologists, they are doing the same thing for 20, 30 years. So it's very hard asking them to change the technique they are using for 20, 30 years overnight. And focal it's a very new concept. And again, even people, it's funny because years ago when we were running clinical trials with the MIT, they put in a meeting room the biggest guys in focal therapy in the world. Mark Emerton from University College London, Samir Taneja from the NYU, Eric Klein, who is the chairman of the Cleveland Clinic department, people from Duke University, all the big guys are there. So they talked for 2 hours, trying to have some kind of a protocol for defining who are the candidates for focal ablation.
Right.
2 hours later, the only consensus they have is there is no consensus. So there is no established protocol for the ideal candidate for focal therapy. And then we start using that commercially, exactly the way the academics are talking about. 2 lesions is not a good candidate, just on side, just Gleason 7 is the maximum Gleason score you can treat. But then one day, one of the patients, that happened to us, one of the patients that wasn't a good candidate asked to talk to me. So the patient asked me, look, I have a much younger wife. I know the risks. I understand the risks. Can you do? I cannot say no, right? if the patient understands the risk. But our experience is, we have done much beyond what people think that can be done in focal ablation, much beyond, with good results. And also there is another aspect. Once we treat those patients, we keep monitoring them. So we have a PSA after 3 months. And so if the PSA, they go down. The PSA, like this gentleman I was mentioning, was 5 or 6, 0.4 1 year later. There is no reason for biopsying those patients or getting hurried or whatever. And if it happens to have the PSA going up after 6 months and so on, we can repeat the biopsy and can even eventually treat again. So it happened to us to have several times. We treated just one side of the prostate, and 2 years later, the patient came, we found a lesion on the other side, and we treated again. So this is what we have been doing.
So you can repeat, you can review it and go back and repeat it on the same prostate?
We can do that.
And how do you keep it encapsulated in the prostate and not, you put a barrier between the rectum and, or the urethra, or you just sort of, you eyeball it with your,
Yeah, the coil is so precise, we don't have to put anything in between, because when we see the coil on the ultrasound, and we know 1 millimeter away from the coil, there is no tissue lesion. So it's very precise. We can put very close to the capsule, destroy only what is inside, and not damaging anything outside.
now the ultrasound is capable of detecting this at the minute level,
Yeah.
the cancer tissue.
Yeah.
And if it's not a lesion, then it doesn't affect the tissues around it.
Yeah, the ultrasound shows us very clearly the lesions. We use the state-of-the-art Hitachi ultrasound, and we see very well the ultrasound.
I've had ultrasound guided biopsy through the perineal ultrasound biopsy, and it was a little uncomfortable, but it was precise.
It's precise.
You know, and it did have a little. You had side effects for a couple of weeks. You were blood in urine and that sort, but just trauma to the
Urethra.
and to the surrounding area. So,
Yeah, the trauma we generate into urethra here is by far less than a biopsy, because on the biopsy they have to puncture several times in different places, and we are more localized. So, and we don't generate lesions outside the coil.
but you do have to puncture the gland anyway to get your needle in there to do the ablation.
Yes, correct. But the number of insertions we have is inferior, is less than the regular biopsy.
Now to encompass the whole area, if you have a fairly involved, let's say, Gleason score, now you would do it in for the entire prostate, or you would just focus on particular lesions, or just areas or sections, or how would you go about it if let's say you thought the whole prostate was involved?
When the whole prostate is involved, we destroy the whole prostate. So we come with coils here, and then we place coils on the other side, and anteriorly too, and then let's say 89% of the gland is ablated.
Now, do you determine that the whole prostate is involved through biopsy, or do you determine that, or do you determine that through your ultrasound detection?
Biopsy.
Through biopsies.
Yeah.
And you say above a 7 Gleason is not recommended for this particular technique?
We have done some, but the patient has to understand there is a risk. The risk, because those are more high-risk patients, right? So those patients we keep more closely monitored to make sure the PSA is down. But we can do more.
And what is the risk? That you're not getting all the cancer? Is that it?
The risks we have here is we treat one side and the cancer can pop up on the other side later. This is one of the risks. That's the number one risk.
The cancer can occur within that 1 millimeter too, so that's always a risk too.
No, actually, when we destroy part of the prostate here, we destroy the vascularization of the prostate because it's turbocoagulated. So there is no blood flow in the side of the prostate anymore. So there is no cancer. Once it's ablated, there is no cancer anymore on this region.
The cancer cannot grow
Without vascularization.
anymore in that destruction zone.
It's a totally dead tissue.
Now,
I've already had IMRT treatment. Prior to that treatment, I had a biopsy, which was like 21 points or whatever, found to be very localized. So the IMRT apparently was very focused and did a good job. My PSA had
Went down, okay.
way down, below 0.3, I think was the last.
That's good.
So nice. However, farther down the road, I got a cancer somehow, originally, somewhere down the road, it is possible I could get another cancer.
It is possible,
Now,
because,
excuse me, let me, if I may, please.
sure.
So my question is, has the treatment, IMRT treatment, changed any cellular structure in the prostate or around such that this will not work effectively again? Because the point is, I have been told, no more IMRT for you. We have seeds later on if we find something. Presuming there's no metastasis.
Yeah, presumably there is no metastasis. Yeah. Actually, we have treated a certain number of radiotherapy failures. So we can treat patients who had an MRT and have cancer again in the region. That's not a problem for us. We can come and treat the same way.
And it works, I mean, the treatment itself, the IMRT treatment, you can't repeat it because it's already done something to
Yeah, but
the tissue.
we can still place our coils on this region where we have radiotherapy. We have some fibrosis. So the insertion of the coil sometimes is a little bit more, you find a little bit more resistance, but we can do anyway.
You can do it.
Yeah.
How about, just as a side question, is this being applied to breast cancers?
We never use that in breast cancer. No.
Okay.
What is IMRT?
It's image modulated radiation therapy. It's where they control at a higher intensity. They can direct focus on the tumor at a high intensity.
Radiation.
Yeah,
It
it's
is
going around.
radiation, yeah.
Am I wrong?
Yeah, no, it's totally correct. It is radiation, and it's controlled by a computer, and they try to focus as much as they can on a given region. So that's.
But radiation doesn't have a barrier, it doesn't have a stop point, it can go outside of a membrane.
The problem of the radiation is two problems. Is they have a hard time to destroy a bigger zone because they have to concentrate on a given region, what we don't have. And the second problem is for getting, for example, in here, they have to cross other tissues, okay, even if it's focused. So we have some damage around. Hopefully that didn't happen to you, but in some cases can happen.
They had a lower intensity around
Okay.
and a very high intensity focused on the tumor. And it was all, and they inserted a barrier to separate from the rectum. And additionally, inserted a balloon in the rectum to further pull the rectum away from the barrier and the prostate.
And that reduces
Well, the
side
balloon would
effects.
seem to expand it, so that almost sounds contrary. If you would put a balloon in the rectum, it would seem that it would expand.
Well,
it
if
rather
you
than
look at it from a
vacuum
cross
it.
section though,
Yeah.
what it does is it pulls more away. It's pulling away from the prostate. So there's actually less mass exposed.
No, that minimizes the side effects.
Yeah, but sometimes the thinning of the tissue at that point makes it more vulnerable for
Well, you have a barrier also.
Yeah.
You have additionally, you have that wax barrier. But I'm not extolling the virtues of IMRT. What I'm really questioning is now I can't go back to IMRT. They say that. Now, as you just pointed out earlier, schools of thought may even change on that. I don't know.
Yeah. And they have as well some limitations of the existing technologies. Some technologies, they have their own limitations. So, and then it becomes very complex to go beyond the limitations of the technology. That's the problem.
But it's encouraging to know that this continues to be effective should I get a recurrence of a.
Yeah, hopefully it won't have, but yes,
Because once you reach your radiation saturation, you can't go back for any additional.
Well, you
have
can
to
go
do
back to
ablation.
radiation, but using seeds.
Right, yeah, but even
That's kind of what's been facing me, and the reason I'm so interested in this.
yeah, and the seeds.
I would like to see some alternatives.
Yeah, the problem with the seeds are a very old modality, and there's a radioactive seeds,
Yeah.
and they keep destroying tissue over time, and you end up having side effects because you cannot stop this radioactivity to destroy tissue over time.
and it leaves the envelope too.
Yeah, exactly.
That's the biggest side effect of the radiation is that it leaves the envelope and it can affect other organs. So that's,
Exactly.
That's a real setback.
Yeah, but the seeds are less and less used. It's almost a dead modality now.
Is that right?
Yeah, almost dead.
Well, I started out not even thinking that, I didn't even want to accept that I would have to have them, but if you're stuck with no other alternatives, seeds are at least something.
That's right.
And then I guess the seeds are high intensity, short
Yeah.
half-life, or low intensity, long
Different
half-life.
kind of seeds. But there is also another aspect of the treatments people don't tell you very often is if you go for a prostatectomy, robotic prostatectomy, after the prostatectomy, between 10 and 20% of the patients, they still have cancer, even when you remove the prostate. This is something that the surgeons don't tell you, but it's the way it is.
I had my prostatectomy about 13 years ago by Dr. Catalona, father of PSA. And my tumor was, I don't know how it shows on this diagram, but it was up towards where the seminal vesicles lay. Would they be on the top as we're looking at this?
Yeah, it's more posterior and more, because this is a slice. The seminal vesicles, they would be on the layers behind this layer here.
Okay. Now, had this procedure been available 13 years ago, and I don't think it was.
Right.
And if it was available, it wouldn't do me any good because 5 days after my surgery, I got a call from Dr. Catalona saying, I'm sorry to tell you, I didn't get it all. When I took the prostate out, there was still traces in your seminal vesicles. And
We have seen that.
and there's nothing you can really do with ablation then. It's too far gone, correct?
No, we did some patients. As far as we can see the structure on the ultrasound, we can get in there with the coils and then wait.
Okay. Because I had IMRT because the cancer came back 6 months later, right on schedule. And I made the mistake of not going to Northwestern for that. I went to a smaller hospital because it was wintertime and it was closer. And they not only missed the target in the bed of the prostate, they hit my right hip, and now I'm walking around on a hip made out of titanium. And I always had the question in the back of my mind if there would have been some way to attack the cancer. It was a Gleason 7, and I always had in the back of my mind, well, if I would have had the IMRT first, could we have stopped it from going into the seminal vesicles? But I don't think so.
Just to chime in here. So 13 years ago, again, as we discussed, technology advances. There's a new technology now which can pinpoint cancer that has potentially moved outside of the prostate. It's called PSMA PET scan. So they put a radioactive tracer and you can visualize on an imaging where the cancer is. Had that been available, or had this been today, you'd probably be recommended to get that first. So now your decision process takes a different turn.
Right.
But again, they didn't have that then. But Dr. Faure is right. We've had patients come to us understanding that they've had localized prostate cancer, but we can get the coil into the seminal vesicle, and we can ablate that. So
Yeah,
that
that
has
has
been.
This is it. This
So
is
if you-
really makes you go away from there with a different feeling. There's something out there. And you guys, I hope you don't stop studying all the time. You know, don't go home and drink wine, you know.
Oh, so how do you think he came up with the coil?
This is how the whole idea came from, right? That's not water.
Tell him it's a true story.
So what you just said, if you've already had that PSMA scan, and I had the prostate removed about 1.5 years ago, and now they found something outside of that. Is this kind of treatment still available for that kind of thing or not?
Yes or no. It depends if the structure can be seen on the ultrasound. Because I need to see where the tumor is on the ultrasound to place my coil in there. Right? But if it's on the region where the prostate was, there is a big chance we can see that on the ultrasound. We have done some patients after prostatectomy, they had part of the prostate not removed and the cancer was there. We could see on the ultrasound, then we could get into the coil, into this region with the coil. So it's possible. I cannot say it's 100% sure,
Right.
because in some cases it's not visible in the ultrasound, so then you cannot get in there. But in most of the cases, you can get in there.
But if it's shown up on that scan, right,
I
it's
can-
been identified where that is.
Then we can get in there.
The coil, that radiation,
And there is radio frequency.
radio frequency
Yeah.
destroys, and you're saying that there's no side effects then?
There is no side effects because we keep the coil protecting the structures around.
The structures around.
How big is the coil? How, are they different? Do you use different size
Yeah.
coils?
Yes. We have a range of different sizes.
Well, for example, a
8
couple of millimeters? or-
8 millimeters is the smallest one. 8 millimeter is the smallest one. And then we have 10 and 12. We don't use beyond 12 because it's too big.
Yeah, and the wire is itself like,
Actually, it's called nitinol. It's a medical grade alloy. It's a very stiff stainless steel, medical grade stainless steel.
It's like a pencil lead. Can you give us is it the size of a pencil lead or the smallest drill bit? Or
No, the wires are very thin. Like it's a needle, right? The coil is a curved needle. You know?
oh, okay.
So the damage we do on the skin is like inserting a needle. You know? So
It's not too flexible.
it's a little rigid.
Do you have one with you?
No, I should have brought one. Yeah, I should. Yeah. No, it's rigid.
If you were not a candidate, let's say for a HIFU type of ablation, would you be not a candidate for this kind of treatment?
That's a very good question, but we have seen this gentleman I was mentioning to you, the friend of us we have treated. He was turned down by the HIFU people, and that's not the first patient we had like that because they don't feel comfortable. They cannot do that. If there is cancer on both sides of the prostate, they don't touch because they know they will miss, so then they prefer not touching. And the HIFU also has another limitation: is that they send the waves from the rectum. So if the cancer is anterior, they have a hard time to reach.
It's more of a linear ablation, so they're going along in a sort of a chop
Correct.
pattern like there. Whereas you're saying the coil is stays within the capsule of the prostate because of your placement, and not because of going like along let's say a width.
Correct.
We get calls from patients that have been turned down for a HIFU all the time. And this is the main reason, is because their cancer is in the anterior region over here. Because HIFU is putting the probe in the rectum, and shooting the high frequency ultrasound across the entire prostate. Whereby I mentioned before, we're inserting transperineally, we can go right from this angle and hit that tumor. So we get calls from HIFU patients that they thought they wanted a HIFU, and HIFU cannot touch those regions of the tumor.
Because the HIFU send the waves from here in trenches, but we came from here. We insert our coils from here, from the perineum, so we can reach any region of the prostate.
Are there positive side effects? You know, we always say side effects are negative, but are there positive side effects such as reducing the volume of the prostate? BPH is
That's I would say so a smart question. This is something only a neurologist would ask you as a question, because it's an excellent question, you know. So the answer is yes, happened to us in a couple of patients that had BPH, because we thermocoagulate the process, so the volume shrinks, and in some patients, the BPH, the symptoms were much better than, but it's a side effect.
Yeah, we could hope for that.
It's a side
We had to
effect.
have it.
It's not the intention of the treatment, but happened in some patients.
But now, if you're aiming for the particular lesions, then you're keeping the other part of the prostate intact, so that's still a functioning gland at that point?
No, if you destroy most of the prostate, the prostate is not functional anymore. But you know, that's not a big problem. You can live without the prostate. You know, so the function of the prostate is not vital for you. So it's much better avoiding to destroy the nerves around and destroying the cancer at the same time. So that's
the destruction of the prostate, how does that affect erectile dysfunction?
no, the prostate has nothing to do with the erectile dysfunction. The erectile dysfunction is the nerves around the capsule of the prostate. But they're very, very hard to avoid because they are really close to the prostate.
But they're not necessarily seen with the ultrasound visually.
We see them with the ultrasound. On the
You see
newer,
you see the nerve clusters with the
Yeah.
ultrasound.
yeah, on the newer areas, the etages, we see them.
I'm going to pass around a most recent photo of the coil in the prostate that we see on ultrasound, so you guys can take a good look at it. And then we're going to, I know you have a lot of questions, but we also have Derek Host here. Derek lives in Sarasota as well. And I mentioned earlier.
I would like to introduce Derek. Yeah.
Go ahead. You want to do it? Yes.
So Derek is part of our team.
Oh.
Derek is helping us in the business development, and basically he's in charge of building our organizing the whole thing
I don't know if
and
that's
building
just-
our new clinics.
maybe-
So maybe Derek can say some words about that. Thank you.
So, if you thought that was interesting. Banking and financing and real estate, that's what I cover. So, that gentleman that Andre talks about is one of my business partners, actually one of my key business partners in real estate development. I'm a real estate developer with a background in private equity and a background in medicine. I've helped 1,200 doctors and dentists open up their offices around the United States. And just so happened that our Venn diagrams overlap by that gentleman who was 57, that really the diagnosis and then failure to be treated properly wrecked him and his whole family. He went from being a vibrant human being within a year totally getting depressed and foggy thinking, and his family was worried, obviously. And then he met Andre. I didn't know Andre at the time. And 2 visits later, he's cured. He's a different human being. He's optimistic. His family life's better. And then he introduced me to Andre so I could help him find real estate. And we had to sit down and think, okay, obviously this is an incredible piece of technology. However, how do we get that into the mass conscious of the urology field around the United States? Where do we open the very first one? Why do we pick that place? Andre's been doing these procedures in another urology practice in Orlando and Naples, but how do we get mass focus in Florida first, and then where do we go from there? So we landed on Sarasota, luckily, because it's really 2.5 to 3 hours from 12 million people, 6 of whom are men, and 40% are in the right age demographic. So we're going to open up our flagship first office on Fruitville Road, east of I-75, right in front of Kennedy White Orthopedics, 30,000 square foot orthopedic surgery center, which is currently under development, which you can see if you ever drive out Fruitville. Our office is going to be 5,200 square feet right in front of it. And quite frankly, within driving distance in Sarasota, 30 minutes from any point in Sarasota, Longo Key, you get to this location. Yeah. That's our first location. It'll be open hopefully in November, possibly December, as everything's been delayed in commercial real estate. And this is one of 4 that we're going to open in the state of Florida, and then progressively grow from there in conjunction with some acquisition of urology practices. So our long-term vision is to couple these. How do we get mass appeal? How do we get mass exposure to this technology? Informing urologists across the country, starting in Florida, then going to the Southeast, and then taking that nationally in conjunction with urology practices and our de novo approach. De novo being a brand new location. Our location obviously is going to be the destination for much of the 2024 calendar year. 2025, we expect to have others in Miami, possibly Naples, and then off to the other states.
Do you have a reason?
No, no, we don't want to read. I started out as a private equity analyst and then a portfolio manager in private equity, and we don't need a read.
Okay, good.
Yeah, so first things first, I mean, on the business side, if that's interesting to you, I'm happy to dive into that a little bit, yeah.
What's a REIT? Yeah.
A REIT? A real estate investment trust.
Oh, yeah.
So real estate isn't where we want to put our liquidity. Let's just say that.
It's
Yes, yeah, real estate makes us 10% a year. You know, we can't grow by owning real estate. We really need to get 80 locations across the country to get as many people diagnosed and properly treated as possible. We can only do that by being a little bit more nimble.
Is this tied up in copyrights, patents?
Thankfully, Andre already did all the heavy lifting.
We have patents.
You know, he's already gone through years and years of clinical trials and patents.
So it's licensed, you would maybe license to physicians
No,
to
no.
acquire, no?
No, because the problem is, if you start licensing, you lose control of what they are doing. We want to keep the outcomes the way they are right now, very high level. Very, I would say, beyond everything else.
That's a 99% success is
It's high.
Because I don't know about,
have 100 samples of.
Exactly.
Is this Medicare approved?
No,
No,
it's not.
FDA.
Not Medicare.
We don't want it to be.
So it's all private insurance?
So all
private pay.
Yes.
It's private pay, yeah.
And who determines whether you're a candidate for this particular kind of treatment? Who do you work in conjunction with to determine who's a candidate for this particular kind of treatment?
The problem is, it's a complex question because first, the first number one thing, this is what we think is the right way to do, it's the patient's choice. Okay, so we inform the patients. The patients, they have information about all the modalities of treatment. They talk to different doctors. We have our doctors. Okay, they can talk to our doctors too. They can talk to other patients we have treated. That helps. But the final choice is the patient. The only thing is, we do a PET scan. If the cancer is outside the prostate, we don't touch.
You
How
have
many of
doctors
these
here.
have you done?
How many?
Yes.
200.
So including the clinical trials, we are, I think, right around 180, 190. I lose. I go back to my log.
190 of these procedures.
Correct. We started, so Dr. Faure brought the company to the US in 2017. We met and we commercialized in 2019. COVID bit at our heels a little bit, but we kept on pushing. We have, again, the 3 centers of excellence. We've treated patients from all over the world. We have patients coming from Canada, from the Northeast, from Chicago, from LA, Texas. They come everywhere, and they're going to start coming to our clinic.
Is this FDA approved?
Question, what's the average cost of a treatment? Since it's not covered by Medicare, what's the average
Yeah,
cost?
so it's a good question. It's a good question. So it's relatively affordable and cheap when you think about it. So let me put it into context and perspective.
Right.
HIFU and Tulsa HIFU in Sarasota is relatively priced between $30,000 and $40,000, and we know the side effects, the inefficiencies of HIFU. We are half that, so we are priced at $20,000, and that includes everything: the anesthesia, the pre-op, post-op care, and the follow-up with the PSAs for 1 year.
So what kind of PSA level do you expect after a treatment?
So typically, I'll let Dr. Faure answer the PSA question.
Well, what is the question? Sorry.
The question was, what kind of PSA levels do you expect after treatments and for how long?
Yeah, so typically, it depends on several things because if we do the whole gland ablation and patients that have multifocal disease, bilateral disease, so then the PSA goes really, really down 0 point something, because technically the patient doesn't have a prostate anymore, almost doesn't. If you treat just one side of the prostate, obviously where the cancer is, the PSA will go down. But part of the PSA comes from the other existing part of the prostate. Doesn't mean there is cancer there. So, but the general experience is the PSA drops significantly, very quickly.
To what level?
It depends. It depends on what is the initial PSA. It depends on how much of the prostate we have destroyed. This gentleman, who is a friend of Derek, we treated. We did the whole gland, was 5 something. His PSA today is 0.4 1 year later. So
He changed his diet, he changed his lifestyle. There's other things that help, but it was
yeah, but
100% you.
the PSA went to 0.4 very quick.
You know, but that, life changing, quite frankly.
One thing that I think that I see from this is not destroying, if it's effective, but it seems to be, but it's not destroying factors which affect ED, for example.
No, it's not. No.
So I used to be the banker for the High Food Act, just so you're aware. And I helped them with the financing aspect of it. Patient selection is the key. I mean, talking through this, they only pick clients that they know are gonna have 100% success. Andre, much more cutting edge in the way of what he's willing to take a risk on trying. I don't wanna,
Yeah.
overemphasize that, but, patient selection, you can, reality is two different things, right? You can take data that you know is going to fortify your case and put it into one set with ignoring a bunch of data that you didn't use. And so 99% successful, even with very, very challenging cases.
Well, one thing, it seems prostate cancers hopefully are in the range of slow growing, like months rather than days.
Most of the cases, yes.
So if you missed prostate PSA doesn't go down,
right,
you're still looking and you can go in and do something again. It isn't like the radiation thing that you can only really kind of do it once and then you got it fine. If you didn't, you didn't.
That's correct. Do you have any doctors in this area that are proponents of this particular method?
We hired one doctor that will come here in our new clinic. He's coming from Naples.
A urologist?
Yeah, a neurologist.
We only work with board certified urologists.
Yeah, of course.
And an oncologist also?
We work with oncologists, but in our clinic, we're going to use our own urologist. But he's a neurologist oncologist. He's specialized in prostate cancer. Yeah, this procedure has to be done by a neurologist.
With all the urologists that are in Sarasota and Manatee and so on, have you made any contact or much contact?
Okay.
You want to tell the story?
Yeah, I don't like to talk about that, but the biggest problem is, and they cannot see me here on camera, so thank you. The biggest problem is, years ago, the radiotherapy companies, they realized they did not have access to prostate cancer patients. And prostate cancer patients, for them, is a big business, right? Why they did not have access? Because the patients, they go to the urologist, right, when they have a prostate cancer. The primary doctor sees an elevated PSA, sends the patient to a neurologist. So what they start doing is they start buying urology practices, and this became a big thing. So we have massive companies owning most of the urology practice and smaller companies too. And all those companies are radiotherapy-based companies. So basically, the doctors became employees of those companies, and they have to send the prostate cancer patients to radiotherapy. So most of the doctors in the region here, it's not only here, it's everywhere, they work somehow for a radiotherapy-based company. Most of them.
You've heard of 21st Century Oncology?
Yeah.
21C or Genesis Care? Or
Genesis Care.
They're all radiotherapy.
These are all owned by radiotherapy companies.
So the doctors are paid for sending patients to radiotherapy.
Well, it's kind of similar to that on the Da Vinci.
Yep.
You've got a huge investment in the equipment.
That's right.
That's right.
That's right,
So you can't leave the equipment just sitting there, so they're gonna recommend it.
exactly.
Well, that's how it was originally with robotics too, in that respect, they had, robotic surgeons.
Well, that's what I'm
relying
talking about.
on it, Yeah, yeah.
Prevention
Yeah.
robotics.
Yeah, it's exactly
Of
the
course,
same thing.
They're doing the same thing.
In one respect.
Without massive side effects.
Yes, yes.
So not much luck with the urologists, basically, huh?
I'm sorry.
Not much luck with the urologists in
Getting
town.
them on board.
In town, no.
No. Some of the issues with some of the urologists, like Dr. Faure mentioned, is that they're used to doing their modality, what they specialize in.
It's precisely what we run into.
Yep, they're
Just as a-
surgeons,
As a group.
they wanna do surgery. If they're part of radiotherapy companies, they wanna recommend radiation. There's
Exactly.
very few that are young, upcoming, and independent, where they can do their own thing.
Yeah.
Luckily, we've had some in Naples, Myrtle Beach, South Carolina, and Orlando that are just what I described, that have adopted the technology.
That's right.
That's why we frequently talk about oncologists here, hematology oncologists, who have a broader perspective and less invested in any particular
Correct.
Sure.
methodology.
Correct.
Question?
Where does this procedure fit in comparison to the gamma knife? And what's the new radiation?
The TOSA or the TOSA Pro?
No, the also.
HIFU, you're not done HIFU?
We talked about it, the new procedure,
That knife that you're talking.
gamma knife and
Cyberknife?
cyberknife.
Cyberknife is just a shorter version,
And
Yeah,
then,
the nano knife is the one used in prostate cancer. The problem of the nano knife is doesn't destroy tissue in the process, destroy very little tissue. Yeah? Actually, the company that promotes, that owns the technologies, Angio Dynamics, the company, I know the company well. They did clinical trials in London, University College London, just before I did mine there. And I saw the results, because I saw the protocol too. They're beginning when they were launching the results. And they had more or less a recurrence rate of close to 60%. You know? It's very high recurrence rate. And then they stopped for 3 or 4 years promoting that for prostate cancer. They were focused on pancreatic cancer. And then all of a sudden they came back to prostate cancer again. But it's a modality that never really worked in prostate. You know? It's like the laser. Right? Some people, and interestingly enough, most of the people using laser ablation for prostate cancer, they're not even urologists. You have 2 or 3 on the East Coast, and in Texas too. But again, the laser destroys a very, very small portion of tissue. So you have to combine a multitude of different ablation zones for having a bigger volume. And obviously, you let cancer between those multitude of ablation zones. So it also has a recurrence rate very high, like the nano knife.
proton treatment is what I was trying to.
The proton is a new modality, we don't know yet, but the proton is more on the radiotherapy side. It's a radiotherapy side.
Well, the IMRT is a proton.
They use proton.
Yeah.
Yeah, but you can use the classic radiation with the same kind of technique. But the proton is a newer version of the.
Isn't that just a higher dose of radiation?
It's a different modality, a different particle of radiation. Yeah. It's also big investments and big companies. And,
Yeah, because of the equipment.
yeah, and the equipment are very expensive. So,
Yeah.
30 million.
Yes.
But it still is a radiation. And
It still
has residual radiation.
Still is radiation, yes. Still is radiation.
That new location is going to open up in November, you say? Is that going to be just before Thanksgiving? And what's the address of the new location?
Derek knows the address, but it's
do.
under
So do you know where the
construction.
Frugal Library is?
Oh, yes, that's
Right
the
by
one.
Celery
That's
Fields?
the one I go to the vote.
Right, so,
Yeah,
so
okay.
we're right next, we're just to the west of it.
Right, yeah, I'm about 3 miles from there.
So they haven't assigned an address for that facility
Right,
yet.
but I know where the,
But
right.
it'll be the first thing you see off the
Yeah, right in the
highway.
bag, right, yeah, sure, okay.
No, before you get there, you remember where that one
Is it gonna have a bigger electronic board on the front with
I recall
Keratin,
reading.
We're actually the ones who,
I'm
we
sorry?
spread, yes, it's actually one tank tap.
Don't aggregate yet, don't aggregate yet, but you don't know if it's gonna be before Thanksgiving or after Thanksgiving.
You know, I wish I could control
That's-
zoning of
that's-
Sarasota
that's-
County. I mean, right now, we have an architectural meeting right now.
Okay.
Pass that around, they'll sort of pass it around, that shows the needle on ultrasound.
You have a question?
I recall reading some time ago about when they do needle biopsies, in extracting the needle, then the problem, the imagined problem, was seeding the needle track. Now, one of the solutions that came up in Germany was using needles with radio frequency.
Yeah, exactly.
This is really quite similar in some respects, I believe.
Yeah, actually, the radio frequency technology is not new.
Yeah.
We use radio frequency for treating cancer. Started first in liver cancer for many, many years. So it's a proven technology.
Yes.
But we use that in a different way. We shoot the technology. That means we use the same proven technology with frequency, but the shield prevents that to go beyond and prevents the side effects.
That's really what the coil, this
That's-
whole thing is shielding the radio frequency.
Exactly.
Well, because it
So
doesn't go
that's the
outside.
plan. That's what we did actually.
Well,
Very active.
A urologist I went to, I had two lesions, one at 7 and one at 6. And
I have a question. A question.
But they said that.
What size is
The lesion that has the higher number, I guess the 7, it would lead to 6, and that the 7 dictates the activities of the 6.
That's a big debate. That's my friend Mark Emberton from University College London. He's the big advocate of this thesis, considering the index lesion. Letting the other one.
Leaving the other one
Yeah,
alone
yeah.
and just killing the index.
My experience is you found 2 lesions, ablate the 2 lesions, right? Because there is no reason for letting an active cancer lesion there, knowing I'm already there. It will take me 5 minutes or 10 minutes more for getting rid of this lesion too. And why would I let this lesion there? There is no reason for me, you know. So.
What does Mark say about that? I'm curious.
The problem is, the problem is very simple. The problem is the technology he had at that time is HIFU. So HIFU is difficult to use. HIFU is difficult to focalize. They cannot focalize. So, so for them, technically, destroying an additional lesion is a big deal. For me, it's not.
It's a big deal until the second lesion.
For them, it is using the HIFU.
But that's not what Emberton's talking about, is he? You're saying.
And Emberton, he says, destroy the index lesion and let the other one.
Right.
I'm saying, I don't do
You're
that.
saying no, but what's his argument for that? I'm just curious.
Leaving it in?
His argument is the index lesion is going to be the fastest, most aggressive growing cancer.
Right.
Yep.
The other one is going to be dormant and
That's his.
Not bothering
That's
you.
his
That's-
thing.
yeah.
well,
I don't
I
have
would
that.
tend to agree with you. I mean,
I don't have
Mark
that.
Emberton's a
if
great guy.
you're in there and you see a lesion,
He's my friend. He's my friend. And he's a great
Yeah,
guy.
he's a terrific guy.
And no doubt. But
And the reason why they don't do the second one, doctor, is because they can't.
I think big part of the problem is the technology you have. Because if you have a technology like ours, I have a second lesion here. It will take me 5 additional minutes to destroy. And I know I'm not going to do any damage around. So that is a no-brainer. I don't have to think about that, you know.
You're in there already.
Yeah, I don't have to think about that. They have to think about that because their technology cannot do that. So then they have to think about if there is an influence of the index lesion on the secondary lesion. I don't have to think about that. I destroy both.
Are you doing these now in Sarasota?
Naples, Orlando, and Myrtle Beach. Sarasota is to be in November.
So there's no, you're not using any other
No,
surgical facility to do these?
No, because again, all the reasons we mentioned here, most of the doctors, they are either working for a radiotherapy company or they are using a technique like the Da Vinci robot. And it's very hard to ask to doctors to change what they are doing for 20 years because they learned that for so many years. It's difficult to switch to a new technology. And I think we are much better in our own, I would say, in our own facilities. Because at the same time, there is another aspect. Is having our own facility means what? I have the best possible ultrasound available because this is what I need. I have the best ultrasound technician because this is what I need. I have a surgeon who is trained to do that very often. So you don't want to do a prostatectomy for a doctor who does 3 prostatectomies a year. You don't want to do that, right? So then you go to Patel in Orlando, right? Because he's doing millions. They have experience. They have experience.
A friend of mine just had it removed by Patel
Yeah.
2 days ago.
Yeah.
Yeah.
So it makes a lot of sense having a facility where people are trained for doing that and are doing that every day. Makes the outcomes even better.
Somebody online had a question earlier.
Yeah, I'm sorry.
yeah.
I'm sorry.
I have a question.
Okay.
Yeah, say there are multiple lesions and you have to do probe those each. And what kind of anesthesia do you use and how long it will take?
What kind of what? Yeah, usually it's a deep sedation. The patient is on a deep sedation. Could be under general too. We just don't want the patient to move, right? Because we need to place the coils in the prostate, and the patient has you don't see anything. Typically, I would say if it's a small prostate and there are lesions just in one side, typically this should take 20-25 minutes. If it's a big prostate, it's bilateral, it should take 40-45 minutes, more or less.
Well,
So if you're in
all the
post
lesions.
sort of fashion, you're moving in a
Hold on,
post.
Jonathan.
Oh, I'm sorry.
Let him
Oh,
finish.
sorry, TK.
What is the size of the needle? And
We have different sizes. We use from 8 millimeter up to 12.
And another question is that you were mentioning ultrasound guided. I understand that the MRI defines the lesion much better than the ultrasound. And do you identify all these lesions by MRI prior to doing the procedure? Or
Actually, two things here. First, we cannot use the technology inside an MRI because it's too big, too complex, and would make it much more expensive and doesn't add anything. We don't need this degree of precision you have on the MRI for being precise on the surgery. 2 reasons: because we have the pathology report, so we know exactly the regions of the prostate where the cancer is, and we are going to destroy those regions. We don't want to destroy just the 3 or 4 millimeter lesion they found on the MRI because there are more cancer cells around we don't see, and the MRI doesn't see either. So we want to destroy the whole region. This is what we do. We do a more regional treatment, and also this is a big debate with focal therapy people on the academic side. They keep debating about destroying a little zone within the prostate. This is the way we start doing in clinical trials and so on. Our results today are by far better because we destroy a whole region. And the ultrasound is enough to show us with high precision where those regions are, and we destroy the whole region. But of course, sometimes having an MRI before the procedure helps us to see the size of the lesions we found more or less.
Yeah, but you wouldn't be able to operate an MRI in that particular, with the magnetic field, you couldn't operate a Faraday field around that anyway.
Because it's metal, it's a
metal.
status.
You just couldn't operate around.
Anyway, and even if I could, it would be useless because I don't need it.
Well, it interferes with the field.
It's impossible.
It's
impossible. It's impossible.
So what happens, you completed the procedure now, what happens to the materials? What does the body do to get, what happens? Is it heal? Is it scarring? Is it?
It's necrotic tissue, it's dead tissue.
Yes.
Over time, you be fibrosis in the region. Yeah, and the tissue
Just
stays
becomes
there.
scar tissue after a while.
It stays there, it's dead tissue.
Wow.
Those are-
And the envelope of the gland would stay intact, scar tissue would be within the region.
Correct.
How do you measure the effectiveness? You said you did 180. How do you determine success or non-success?
Two things. First, the PSA levels. The PSA levels drop significantly, and they keep on a low level. So we don't have, that's a big debate because some urologists we work with, they want to rebiopsy those patients after 1 year.
Right.
Like our friend, this gentleman we treated, we treated in Orlando more than 1 year ago, and his PSA is 0.4, was 5 or 6 before the treatment, and the urologist wants to repeat the biopsy. I'm against, because there is no need. But basically, to respond to your specific question, the PSA levels, they tell us about the cancer control. That's very important. And then we have as well, we have questionnaires with the patients about the quality of life of the patients. So that those patients, they tell you, my sexual life is normal, back to normal after a couple of weeks. Sometimes we treat both sides of the prostate, because there's also a lot of psychological effect, of course. So sometimes it takes 2-3 months for come back to normal, but they come back to normal.
Yeah, so I talk to every patient twice per year. So initially, right after the procedure is completed, and then 6 months out, and then 1 year out. And that's our follow-up protocol. And overwhelmingly, the patients are doing fine. There's zero issues sexually. Of course, if they're used to taking, oral pills, they can continue that. There's never a problem, but very, very limited side effects.
But you also have, you always have ultrasound.
You have ultrasound or MRI as well that you can always do at a later date. But the PSA, what Dr. Faure was saying, is the PSA is that's the best marker
Yeah,
for
because
control.
Look, if you have a high PSA, they found prostate cancer. We treated PSA now is very low. It keeps low. Why would we repeat anything? Right?
Drink wine.
Drink wine. That's a good good advice. Doesn't make any sense doing anything else, right?
Guys, I think this has been phenomenal.
Thank you very much.
Wow,
Thank you
very,
very
very
much.
interesting. Thank you so much.
I just want to say thank you, David, for what you do to keep us all.
Keep us educated. I keep finding interesting people all over that place, San Antonio.
Take them out there. And one more thing, in November, if that's gonna be the new location for the meetings, not here anymore.
That's right. We'll have a meeting out there.
We're gonna stay in touch, and like I said, I know there's some of you that have been treated before, some of you are on active surveillance. Others of you, again, had radiation. The main thing is keep an eye on your PSA. If you're interested in the treatment, my card is there. You feel free to give me a call for any questions, and I'm happy to answer anything that you have.
Do we follow through you or through the doctor as far as who's getting on board with this? How do we know, how do we get recommendations on people who are finding success in this? I mean, how do we do it through you? Do we do it through the doctor?
Yeah, no, you can do it through me, and then when we have the clinic open, we'll all be available. Yeah, so you can always follow up through me. We have a social media website that we're going to be launching called EvoCare 2.0. It's going to be, and we'll keep you informed on that, so you can send it out to all your.
Contact information is on the.
Everything is on there.
On this TS. On this TS. This is, and your information on that?
Yeah.
You have a form about
It's on the form. I get that on my email.
And then we'll get updates on
Anything for
so it's also the registration.
That's what I'm trying to do. Yeah. But you're working this team, that you're so proud of, right?
This is
No,
so.
no,
Both
I
won
face, I did not.
five national championships.
There's, no.
So he's just, hopefully he won.
I hope.
The women at 11.
How do you erase?
NCAA hockey champion.
How do you, you
Oh,
can
yeah.
cancel
Yeah.
now?
Yeah.
It says, okay, now your PSA is way down.
Little
How do
tiny
you
states
erase-
on the map now.
Yeah.
Yeah, but I wanted, Dave, I wanted Florida, Dave. I wanted the Florida Flames to win that.
So you're telling me
Well, thank you so much.
synergies that, you know, that's what those
robotics
I don't know what you're.
You guys are seeing what's happening down here. My parents are still, more than likely, they're.
The other one is
Social media, YouTube and so on.
Or maybe a combination, which is
without having to attack the body itself. So it was just things that
We have the preliminary floor plan, that's a big sign.
I've been about this.
Everybody has to
That's just coming off the object, right on your right. If you go past the apartment complex. Right in front of this. Right on the door, right on the door. Our office is right on the door. Right behind us. And you can see it.
That can be treated
It's all broken up.
It's a big amount.